had a specialty training in pediatrics in Makati Medical Center, took fellowship training in pediatric hematology and oncology in UST Hospital. So presented various research in and out of the country and published articles on medical journals. Please welcome Dr. Noah S. Sakuti.
So, good afternoon. Let's make this informal, no? So,
Don't forget
so
natin
informal.
i-detail
Yeah.
if you like.
Okay, yeah. So, I'm free to be interrupted if you don't understand anything. So, I'm willing to answer your questions in the middle of the lecture. So, again, I apologize kasi baka medyo highfalutin yung mga sasabihin ko. But I will try my best to work it out with you para at least we can understand each other. Okay? So again, good afternoon. I'm Dr. Noah Sakuti, pediatric hematologist oncologist. And for this afternoon, I was tasked to give you okay. I was tasked to give you a lecture on bleeding disorders in children that you might encounter in your practice and at least recognize red flag symptoms of such diseases and probably prompt referrals if needed to us for the optimal care of the patient. Alright? So I have no disclosures. So, yeah. So the objectives of my talk is to give an overview of the bleeding disorders in children, to recognize clinical manifestations and diagnosis for possible referral. And of course, what's important to you is correlation in dental medicine. I want to present to you oral manifestations of different bleeding disorders and the management to prevent the onset of any complications in dental settings. Alright. So, for a brief background, their blood is a fluid-connected tissue comprised of liquid component called plasma and a cellular component that includes the red blood cells, the white blood cells, and the platelets. So, the diseases involving the blood and the bone marrow are included in the study of hematology. And bleeding diathesis is a function of the different cellular components, the thrombocyte or the platelets, specifically, the plasma proteins, which include your coagulation factors, and vascular integrity. So, hemorrhagic disorders can be congenital or acquired, and they can be triggered by vascular abnormalities, clotting factor deficits, or thrombocyte or platelet malfunction. In children, the most bleeding disorders are more often than not, are congenital and hereditary in nature. And this is the focus of our lecture. Hereditary bleeding disorders, or HBDs, are a group of unusual conditions characterized by an inherited tendency to bleed. The illness has been associated with the mortality and morbidity, particularly in its more severe manifestations, as well as the variety of negative effects on the general well-being of the child. The clinical manifestation of HBD varies depending on the underlying etiology, which might disrupt the clotting factors, the platelets, and the arterial wall. So, children who are experiencing bleeding symptoms can be difficult to diagnose. Some bleeding signs, such as recurring epistaxis or bruising, are common in healthy children. And distinguishing between healthy children and those with bleeding problems can be quite a challenge. So, the degree of bleeding varies with the severity of the illness. The recording of the patient's medical history is a significant aspect in determining the bleeding issue. Congenital bleeding disorders are frequently discovered in childhood, when a bleeding symptom or a family history is reported to the pediatrician or the primary caregiver. The family history may reveal vital clues about the possibility of an underlying bleeding condition being passed down through generations. A drug history should be collected, including prescription and over-the-counter medications, as well as herbal therapies, which could be the source of the hemostatic disease. This may provide a clue to the clinician in determining whether the condition is hereditary or acquired.
Dok, gano'ng kadami po, Dok, yung mga hindi nagde-declare ng mga parents ng mga sakit, ng mga...
Actually, hindi naman sa intentionally hindi sila nagde-declare, but hindi nila alam na may bleeding disorder pala sila, or even sa family history. Kasi if you would ask them, you have to, kasi when you take the history of the patient, you have to ask specific questions eh. Hindi pwedeng, ano pong sakit nyo sa pamilya? Hindi ganun. Dapat ang tanong mo is, meron bang nagdudugo sa inyo sa pamilya? So, those are different approaches. So, the answer of the relative or the caregiver would be different. So hindi sila na-declare, but rather they wouldn't know. So meron ba sa inyo na naoperahan dati tapos nagsali ng dugo kasi dugo ng dugo? So that's a more precise question that your caregiver can elicit, can answer. So kasi pag vague ang question mo, vague din ang answer. So yun. Pero more or less naman, they won't do it intentionally. They will declare it naman kasi takot din sila sa patient for the patient. Alright. So, continuing, the most prevalent hereditary bleeding disorders are coagulation factor abnormalities, which have different prevalence rates among ethnic groups. The overall incidence of congenital coagulation abnormalities in the general population is low, around 10 to 20 per 100,000 people. About 95 to 97% of all coagulation abnormalities are caused by hemophilia, hemophilia A, that is factor VIII deficiency, hemophilia B, or factor IX deficiency, or von Willebrand disease. We'll discuss more of those in detail in a while. So according to the US CDC and the United States Hemophilia Treatment Center Network, as of 2018, males with hemophilia are estimated to number between 30 to 33,000 in the US alone. So the most prevalent inherited coagulopathy is hemophilia A. Hemophilia A or deficiency in factor VIII has a prevalence of 12 cases per 100,000 US males, whereas hemophilia B or deficiency in factor IX has a frequency of 3.7 cases per 100,000 US males. So the other coagulation factor deficiencies such as that of factor 1, factor 2, 7, 10, and 11 are uncommon coagulation factor deficits, but they do exist. So another disease entity would be the von Willebrand disease. It's another inherited bleeding illness characterized by deficiency or malfunction of the von Willebrand factor, which are important mediators in achieving primary or secondary hemostasis. However, this just affects 0.8 to 2% of the general population in the Europe and Americas. So, however, because von Willebrand disease is frequently undetected, statistical prevalence does not reflect the true disease prevalence. So, it may go up. So, it's not in connection to your question earlier, so baka hindi na-detect. The prevalence of von Willebrand disease has been estimated in several countries based on the number of symptomatic patients treated at hemostasis centers, and it ranges between 2 to 3 and 110 per million population. So screening populations, for bleeding symptoms has also been used to estimate it, but estimates around 1% have been reported. Alright, so platelet disorders are another group of bleeding diseases in which bleeding can originate from quantitative or a qualitative defect. Quantitative platelet disorders are mostly caused by thrombocytopenia, that is decrease in your platelet count, with a reported prevalence of 1.9 to 6 per 10 children per year. So qualitative, on the other hand, are caused by problems in platelet adhesion, aggregation, granule release, and signal transduction that are known as inherited thrombocytopathies. Even with adequate laboratory testing, diagnosing the more common mild forms of hereditary thrombocytopathies is difficult. Only 40 to 60% of minor platelet abnormalities can be detected at the level of the faulty platelet pathway. So if you find the previous slides quite overwhelming, we'll discuss them in detail sooner. So before that, let me discuss first what normal hemostasis or the process of clot formation looks like. So hemostasis is a clinical term that refers to the prevention of blood loss. Hemostasis is a three-phase process that results in the formation of a blood clot at the site of the vessel injury. Primary hemostasis due to vascular constriction or platelet plug formation. Secondary hemostasis or blood clot development as a result of the blood coagulation, and fibrinolysis as the final stage as a means to physiologically counterbalance the formation of excessive form clots. So primary hemostasis is an early phenomenon that occurs after the artery wall has been damaged. Vasoconstriction occurs as a result of local constriction of vascular smooth muscle cells. changes in membrane phospholipids, and calcium-controlled 3 steps: platelet adhesion, platelet granule release, and platelet aggregation. So the endpoint is the formation of the initial or the primary platelet plug, which is very weak. Secondary hemostasis results in the wound being permanently closed mechanically, with local fibrin production and the formation of a fibrin-based clot based on the coagulation factors, followed by healing and scar formation. These two processes occur at the same time and are interconnected. Clotting in the secondary hemostasis is achieved in 3 steps. Number 1 is a complicated cascade of chemical events involving more than a dozen of the blood coagulation factors, develops in the blood in response to a vessel rupture or damage to the blood itself. The result is a production of prothrombin activator complex, which is a collection of activated components. Number 2 would be the conversion of the prothrombin to thrombin that is catalyzed by the prothrombin activator. And lastly, the enzyme thrombin converts fibrinogen to fibrin fibers, which entangle the platelets, blood cells, and plasma to form the stable fibrin clot. The fibrin threads are also adhere to the damaged blood vessel surfaces, allowing the blood clot to attach at any vascular opening and therefore prevent further blood loss. In addition to hemostasis, the fibrinolysis pathway is important. Fibrin plays an essential role in hemostasis as both the primary product of the coagulation cascade and the ultimate substrate for fibrinolysis. Its function is to counterbalance by removing or lysing the clot formed by activation of hemostatic pathways and prevent pathological thrombosis. Right. So I think it's not really mandatory for you to know the coagulation cascade, medyo complicated. But what's important is after the secondary hemostasis, there's the formation of your stable fibrin clot. Alright. So any deficiency of your factors there would mean bleeding. No? So that's the pathophysiology of your hemophilia. And even your von Willebrand disease. Alright, so as discussed earlier, hereditary bleeding disorders are classified in 3 broad categories: vascular causes, platelet defects, and coagulation factor deficiencies. For vascular causes, the most common cause of hereditary vascular bleeding disorder is connective tissue vascular malformation. They are characterized by blood vessel development defects and are associated with syndromes. So classic example of bleeding diathesis are the Osler-Weber-Rendu syndrome and the Ehlers-Danlos syndrome. So hereditary hemorrhagic telangiectasia is another name for the Osler-Weber-Rendu syndrome. It is a rare autosomal dominant pathology that leads to mucocutaneous telangiectasia and diffuse distribution of AV malformation in the skin, mucosal surfaces, and solid organs. These patients can develop iron deficiency anemia from epistaxis and gastrointestinal bleeding. Most of the patients remain asymptomatic and becomes apparent in the 4th decade of life, so during the 30s. So the incidence of occurrence of HHT is about 1 in 5,000 to 8,000 people across the globe. So the Curaçao criteria in 1999 has been set to establish the clinical diagnosis of HHT. A positive screen would that be a 3 or more criteria and confirms the diagnosis of HHT, and specifically epistaxis, which presents around 90 to 95% of the time, telangiectasia in the oral cavity, nose, lips, and hands, and visceral lesions, and a positive family history. The most common manifestations of HHT are epistaxis, facial telangiectasia, and hand telangiectasia. Some would present with pulmonary AVM and gastrointestinal bleeding. So AVM can also develop in any system, including the spinal and the coronaries and the renal system. Alright, so what are the dental pearls for management of HHT? In a diagnosed case of Osler-Weber-Rendu syndrome, visits the dental clinic for any dental procedures, these patients should be advised to undergo screening through CT scan, MRI, and ultrasound to rule out any AV mals and other systemic involvement to avoid any dental complications. So you dentists must be aware about the complications associated like hypoxia, pulmonary or cerebral embolism interfering with the dental procedures. So dental chairs need to be kept upright while performing the procedures, and oxygen should be made available in the clinics. For invasive dental procedure, antibiotic prophylaxis needs to be considered for these patients to prevent any infections and cerebral abscess. So Sen et al. Found in a study that the same anaerobic organism aspirates in the cerebral abscess from HHT patients resembles that of periodontal infections. So HHT patients with anemia should also avoid undergoing invasive dental procedures that can exacerbate the anemia. Local hemostatic measures need to be implemented for the procedures requiring manipulation of the soft tissues. Alright, so next disease would be the Ehlers-Danlos syndrome. It is a fibrillar collagen metabolism defect. It is also known as X-linked cutis laxa. It is an X-linked recessive condition that leads to the deficiency of the enzyme lysyl oxidase. So lysyl oxidase deficiency results in abnormality of copper metabolism and excretion that cause deformations of connective tissue and skeleton. So various types of EDS have been described in the recent classification in 2017, but the 5 subtypes are the most significant ones. That is classical EDS, classical light EDS, cardiac valvular, vascular, and hypermobile. Classical and hypermobile are the most common ones, followed by vascular EDS, representing 5 to 10% of the cases. So the bleeding symptoms in EDS patients vary from mild bruising, hematoma formation, or fatal bleeding episodes. So the tissue fragility, joint hypermobility, skin hyperextensibility, and acrogenic fascies are the most common diagnostic manifestations of Ehlers-Danlos. The classical fascies have a downward slanting palpebral fissure, blue sclera, micrognathia, and epicanthal folds. So neurological manifestations include hypotonia, manifesting as delayed motor milestone in a growing child. Mitral valve prolapse can also develop in these patients, and these patients can also develop arterial aneurysms and intracranial hemorrhages as complications. So in a large cohort study, authors have found that EDS patients have no coagulation deficiencies, but 80% have developed platelet dysfunction, leading to increased risk of bleeding. So it's more of the platelet rather than coagulation factor deficiencies.
Common po siya dito sa atin sa Cavite.
Wala pa akong na-encounter dito sa Cavite. So, for the oral manifestations, there's hypermobility of the TMJ that can lead to frequent dislocation of the joint. These patients, approximately half of them, can touch the tip of the nose with tongue. So that's your positive Gordon sign. So you can elicit by sticking the tongue out. Pwede mo, sino ba? Meron ba? Oo. So, there's thinning of the oral mucosa and can increase the risk of oral ulcerations, gingivitis progressing to periodontitis. So, the fragile gingiva can be observed during routine oral prophylaxis, leading to bleeding. Varied dental anomalies like enamel hypoplasia, especially in the premolars and molars, decalcification of the enamel, shortened roots, and pulp stones are found to be reported in cases of EDS. Okay. So what are the dental considerations for EDS patients? It is crucial to perform the blood test for coagulation factors and platelet levels before proceeding with any dental procedure. The patient's physician needs to be consulted for any systemic conditions that can lead to the complications during the dental treatment. The prevention of dental decay and gingival problems is crucial for these patients. The principles of sustaining good oral health are centered upon dietary restriction of sugars and maintaining good oral hygiene and hygiene regimen. The prophylactic antibiotics are indicated in these patients with mitral valve prolapse kasi they can cause endocarditis. To prevent the risk of endocarditis. Shorter duration of dental visits is preferred to avoid causing the TMJ problems like dislocation. So frequent follow-up is advised. Alveolar nerve block should be given with great caution to avoid causing hematoma formation. Lighter forces should be used using orthodontic treatment due to the fragile periodontal tissues and considering that teeth tend to move faster. So some patients with EDS may develop mouth ulcers due to the trauma of the orthodontic appliance. And this can be lessened by the use of protective wax over the brace and possibly an occlusive paste placed over any sites of ulceration. Invasive maxillofacial surgical procedures should be avoided because of the delayed wound healing and increased bleeding tendencies. Yes?
Doc, how problematic are hematomas for these patients po?
What do you
Kasi
mean?
nerve block po, yung ganyan po namin.
Oo.
Mandibular
So you
block.
cannot avoid?
Hindi, usually we can avoid, but I'm just curious how problematic are hematomas for patients. Kasi minsan po, kahit hindi kami mag-nerve block, minsan nagkakaroon pa rin ng hematoma kahit local infiltration.
Yeah,
So
oo.
ano pong
Oo,
problema
yun.
dun sa hematoma?
Yun yung problem sa condition na it's very fragile kahit nga local nga lang they can have hematomas. So wala tayong specific recommendations for that kasi if the risk of bleeding is much higher than the dental procedure itself, baka kailangan i-defer natin. Oo, kasi baka lalong duguin. They are fragile kasi talaga. Inherently fragile. Wala tayong gagawa doon. Let's see. So, we go now to your hereditary platelet disorders. So, the platelets cling to the exposed subendothelium of a blood artery and secrete their granule contents when the channel is wounded. Platelet abnormalities, whether congenital or acquired, are linked to a higher risk of bleeding, demonstrating the importance of platelets in hemostasis. Hereditary platelet disorders are a rare set of diseases that are divided into two categories, whether it's qualitative or quantitative. Clinical presentation would be the same, owing to the similar pathophysiology affecting the platelets. Number 1 would be your Bernard-Soulier syndrome or BSS. It is a rare bleeding thrombopathy characterized by thrombocytopenia, so decrease in platelet count, and abnormally enlarged platelets. So, dyan sa picture, so these are your RBCs, those are your platelets. Normally, your platelets should be, sobrang liit lang, blood dust sila eh. In layman's term, it's blood dust. So, sobrang liit lang. Pero unusually, in BSS, they are like your RBCs na in size, and they are decreased in number. So, with BSS, the platelet function is diminished or mababa na nga yung count niya ng platelet and then malfunctioning pa yung platelet, so very risky for bleeding. So these patients develop symptoms since the day they are born because they are inherent and experience numerous episodes of bleeding, post-traumatic hemorrhages, epistaxis, cutaneous bleeding, or ecchymosis. The other manifestations may vary from purpuric spots to intracranial hemorrhage, GI bleeding, heavy menstrual cycle in females, and hematuria. Severe bleeding complications have been reported in about 16% of the cases. Adults with BSS have minor signs and symptoms of the disease with less severe bleeding episodes due to platelet reserve. So next would be your GT or your Glanzmann thrombasthenia. It is a rare autosomal recessive bleeding disorder caused by a faulty GP glycoprotein 2B3A, leading to defective or absent aggregation of the platelets, leading to prolonged bleeding. With normal size of the platelet and the number of the platelets. So you have no problem with the size, you have no problem with the number, but the function is faulty. So merong kulang na receptor or mali na nagawang receptor, which is important for your platelet aggregation. So the manifestations of GT usually begin in childhood and gradually decrease with age, as seen in cases of BSS. So pareho naman nilang na-outgrow most of the time. Epistaxis is the most common occurrence in children with GT. Bleeding complications are more severe in females during menstruation and childbirth. The clinical signs and symptoms are almost like that of the patients affected by BSS, and differentiation can only be made by advanced laboratory investigations.
Doc, very common talaga epistaxis sa kanila.
Yes.
So it's one of our screening questions talaga lagi.
Oo. Ganito yan. Kasi when you say platelet disorders, usually, ang bleeding yan, mucosal. So, it's very non-specific. When you say mucosal, pwede yung, most of the time, sikilagit or even epistaxis. So, any platelet defect can actually present with such presentation. So, hindi naman siya specific sa BSS lang or sa GP lang. It's more of reflective of a platelet defect, platelet pathology. So, yun. So, yeah, it's true. It's part of your screening. Pero it cannot pinpoint what specific disease.
Pero at least medyo mas
Oo.
additional guard na pag sinabi na, identified already.
Oh,
So, kasama sa questions.
yeah. Alright. So, another disease entity would be your platelet type von Willebrand disease. It is an inherited dominant bleeding disorder resulting in spontaneous binding of blood plasma von Willebrand to the platelets. So, it results in an accelerated clearance. So, kahit walang rason, kahit walang trigger, nag-bind si von Willebrand, and then nakukonsume yung platelets. There's accelerated clearance of your high molecular forms of von Willebrand factor. There could be a borderline thrombocytopenia because of excessive activation and a prolonged bleeding time because of your excessive activation of platelets associated with mild mucocutaneous bleeding and hemorrhages following tooth extraction, tonsillectomy, or other surgical operations that are common manifestations. Kaya pa ba? Okay. Just
Ask question. Okay na daw, tatanong-tanong lang.
Sure, oo. Oo. Pag may mga hindi kayo naintindihan, don't hesitate to interrupt. So again, anong mali dito? So another platelet defect. So by the name implies, it's colored gray. The platelets are large and colored gray. So yan yung defect. So the gray platelet syndrome is a rare inherited bleeding disorder characterized by platelets that have a gray appearance, severe thrombocytopenia, myelofibrosis. So myelofibrosis, which means yung bone marrow, which is the factory of your blood, is empty. Puro fibrosis lang. Instead na hematopoietic cells, instead na yung normal na blood forming cells yung nandun, puro fats, puro fibers, walang silbi. So, kulang sa blood cells na nagagawa. And splenomegaly. So, these patients are susceptible to easy bruisability, epistaxis, abnormal menstrual flow, like other hereditary bleeding disorders. So, in electron microscopy, it demonstrates the marked reduction of the alpha granules and high serum vitamin B12, which are diagnostic for day platelet syndrome. So, the problem here are the granules, no? Another disease entity would that be of the WAS or the Wiskott-Aldrich syndrome. So, in the picture, anong mali? Yun yung platelet. So actually, the normal platelet would be ito, normal yan. Pero ito pala normal, sorry. Ito, hindi. So, ang problema dyan is konti, thrombocytopenic ang patients, and sobrang liliit. Sobrang liliit. The normal size would be the medium-sized ones. Malaki dyan ng konti. So, maliit yan. So, the WAS is a characteristic combination of severe immunodeficiency. So, there's a triad. Severe immunodeficiency, microthrombocytopenia, maliliit at konting platelets, and eczema. So, it is an X-linked primary immunodeficiency condition. So, WAS is clinically manifested in males, kasi nga, X-linked, with females as asymptomatic carriers of the disease. So, the patients develop skin lesions like eczema with prominent signs of ecchymosis and purpuric spots to the body and are more prone to the recurrent infections. There's always a history of EC, mucocutaneous bleeding episodes, or even ICH. The most common first clinical manifestation in patients with severe WAS is severe refractory thrombocytopenia with a platelet count less than 10,000. So the normal platelet count is about 150,000. Pero sa kanila, severe thrombocytopenia, syempre, pag less than 10,000, mag-bleed ka na spontaneously. So, oral manifestations of virtually, yung mga lahat yung platelet eh. So, they have the same manifestations. So oral manifestations of virtually all the previously discussed hereditary platelet disorders are as follows. The patients have compromised oral hygiene status because of the fear of increased bleeding during brushing. They are more prone to develop dental decay and inflammatory periodontal diseases. And these patients can develop intraoral purpuric spots, gingival bleeding during routine oral prophylaxis, or even experiencing prolonged bleeding after invasive dental procedures. Understandable because platelet ang problem. Hemosiderin and other blood degradation products can cause brown deposits on the surface of the teeth due to chronic bleeding. Owing to the poor oral hygiene in these patients, frequent episodes of gingival bleeding is a constant finding in GT. Instant profuse bleeding can occur following the exfoliation of the deciduous teeth or minor invasive dental procedures. So the management of these patients with bleeding disorders depends on the severity of the disease and type of the dental procedures to be planned. So in these patients with severe bleeding disorders, the challenge is to maintain the hemostatic system and control the bleeding locally and with adjuncts. So evidence of petechia, ecchymosis, hematomas, or excessive gingival bleeding should direct the practitioner's attention toward the possibility of an underlying bleeding disorder. So when a bleeding disorder is suspected, laboratory investigations including blood counts and clotting studies should be carried out. Drugs used for the bleeding disorders usually does not pose a risk for the dental procedures. But in case those drugs need to be withdrawn, it should be done 10 days before the procedure. Why 10 days? Kasi the normal lifespan of your platelets is 8 to 10 days. So usually yung mga drugs natin like aspirin, they are irreversible. They have irreversible binding to your platelets. So antayin natin mamatay yung platelet na yun, bound to the drug kaya 10 days before we do any invasive dental procedure. So 10 days before the procedure and with the consent of your physician. Patient with HBDs usually requires platelet concentrate supplement prior to invasive dental procedure or tranexamic acid to control bleeding post-operatively. NSAIDs are contraindicated in these patients to avoid the risk of bleeding. Nerve blocks are not recommended in the patient with bleeding disorders due to platelets and should be replaced with local infiltration or intraligamentary blocks to avoid hematoma formation. Still, risk pa rin for bleeding, but yun nga, gaya nung premise natin kanina, if the risk surpasses the benefit, baka i-defer na rin natin. Yes mo daw?
Yung sabi mo, yun na petechia, no? Diba? And ecchymosis, ano po yung saan sila mas connected po?
When you say petechia kasi, ano yan yung mga ruptured vessels, no? Maliliit. Ruptured capillaries. So it's always connected pa din sa platelet dysfunction. So anything that is connected with your platelet, whether it's function or decrease in count, ano yan, pwedeng manifest as petechia. That's why yung mga dengue patients, yun yung tinitingnan eh. Kasi di ba mababa platelet nila. So pag mababa platelet nila, dumadami yung petechia because it's a reflection of decrease in count.
Ang ecchymosis naman po.
Ecchymosis, it's pag nag-ipon-ipon yung microcapillaries na sumabog or nag-leak yung mga capillaries because of bleeding, yun yung ecchymosis, pasa. Hematoma is pasa, ecchymosis is mas malaking pasa. Okay. So yun.
So mas malaking problema kapag ecchymosis.
Oo. Pero dapat hindi yan naabot dyan kasi dapat na kontrolan natin ang bleeding beforehand. Or dapat hininto na natin yung procedure if alam natin na may ongoing bleeding na pala.
Doc,
Yes.
is it the same din po ba? Minsan may mga patients kami na sobrang iyak.
Ay, oo.
Pero
Oo.
some patients hindi naman kahit sobrang.
Oo, kasi magkaiba yung mechanism nila. True, petechia din ang presentation nun. Pero, ang petechia ng sobrang iyak is because, nagra-rupture because of the increased pressure dahil umiiyak sila. Pero, ang problema doon, vascular integrity naman eh. So, it's not the platelet count. So, yes, true. They can present with petechia, pero magkaibang mechanism kasi. Oo.
So, hindi siya
Saka kapag
pathology.
saka kapag yung iyak na iyak, usually makita mo yan dito sa leeg. Kasi nandyan yung pressure eh. So, nandyan yung pressure. So, and then, pag petechia, because of the low platelet count, pwedeng generalize or dun sa areas na natutrauma. So, doon lumalabas yung mga petechia.
Hindi po ba
Yes.
siya na yung mga blood disease, hindi po ba siya nadidetect yung newborn screen?
Hindi. Your newborn screening can detect yung mga critical lang. Yung mga critical. Meron niyang list of diseases that can be detected by your newborn screening. Pero ang importante kasi sa bleeding disorders, just like I've said earlier, is history. Family history. Lalo na kapag child. So, wala yung acquired, more or less. So, pag older child na siguro, pwedeng acquired. Pero kapag younger children, more or less, dapat family history yan. Kasi, namamana yan eh. Di ba mga sinasabi natin, X-linked, autosomal dominant. It's more of genetics. So, yun.
Parang yung pag-undiagnose, yun po yung...
Oo, kaya nga, oo. Kasi nga, gaya nung sa introduction ko din kanina, minsan, hindi natin madidistinguish na healthy lang pala yun o kaya may sakit na pala siya. Medyo challenging kasi siya talaga sa diagnosis. Right.
Doc, sorry, another.
Yes.
Regarding the tranexamic acid po.
Mm.
Kasi usually, parang before the procedure binibigay, what if parang
Pwede.
after na,
Pwede continue niyo.
wala pong...
Up
what
to
if-
5 days usually. Up to
Ano
5
po
days.
bang mechanism action po ng
ng tranix?
Ang tranexamic acid is ini-inhibit niya ang fibrinolysis. So when you, di ba, yung clot formed by your secondary and primary hemostasis, di ba yung fibrinolysis na dapat yan, ini-inhibit niya yung fibrinolysis. So, may clot pa din. So that's the mechanism. Alright.
Thank you.
Sige. Alternative techniques, including sedation with diazepam, ginagawa niyo ba to? Or nitrous oxide, oxygen analgesia can be employed sa OR siguro, no, Doc?
Ang sedation namin, Doc, is
Anes.
with anesthesiologist, moderate to deep
Oo.
sedation. Inducting agent is propofol.
Propofol, yun.
Opo.
Same
Yun.
naman with any other, no? Okay. So, can be employed to reduce or eliminate the need for anesthesia. So, patients undergoing, pero it's the call of the anesthesiologist na rin siguro, no? Patients undergoing invasive procedures requiring factor replacement may be treated under general anesthesia in the hospital OR. Rubber dams need to be avoided. Avoid any laceration to the soft tissues. High-speed suction and saliva ejectors need to be used cautiously in these patients. Gel foam soaked in tranexamic acid can help in controlling the bleeding after extractions. So, in order to maintain gingival health, patient needs to be advised on maintaining good oral hygiene. To prevent further dental problems. Periodontal procedures can increase the risk of mobility of the teeth and bleeding gums in the patients with HBDs. Ultrasonic scaling and polishing don't cause any complications in these patients. And in patients with severely inflamed gums, pre-procedural chlorhexidine mouth rinse and local debridement is indicated. Antifibrinolytic agents should be incorporated. So yun nga yun, tranexamic acid. And the periodontal surgical packs to control the surgical bleeding.
The question po ulit.
Yes.
Factor replacement, how expensive po yun?
Ay, mahal yan. Ganito yan. Usually, ang factor replacement, so yan yung mga may hemophilia.
Mm.
So, ang factor replacement is computed based on the weight. No? The usual vial of factor CFC, factor concentrate, yung isang vial na 500 IU, it costs around 8,000. So, for a 10 kilo child, 10 times 10, 1,000. So, usually kailangan yan 1 or 2 vials. So, 16,000. Oh. So, yan ang kailangan. Pero alam nyo, pag hemophiliac naman, it's a different scenario naman din. Mamaya, discuss natin yung sa hemophilia. Usually may access naman sila with the factor concentrate. Meron yung mga meron yung mga local groups na support groups. So nakakuha sila ng factor.
Kasi baka Dok, mamaya, we have a patient na baka taken lightly na, sige po, mag-factor replacement lang tayo as if recommendation
Wala.
Hindi, ano yun, we compute it and then medyo mahal kasi siya. So, clearance na lang. Clearance na lang. If needed to be given. Yeah. Eh, yung mga traffic sa amin kasi, okay, go. No problema.
Para at least we know na it's not taken lightly. So,
Yeah.
referral, sila kasi baka, misa kasi doon mo sabihin nila namin na okay lang po, madali yung magbubuno pero kailangan factor replacement. Kung tapos mahal ba yun daw? Hindi, okay lang, mura lang.
Yun.
Pala,
Oo.
hindi pala ganun kadali.
Hindi siya ganun kadali. Okay. So another disease entity is your May-Hegglin anomaly. So your MHA is the classic form of heavy platelet syndrome. Because of the mutation again in the gene, MYH9 gene, it is a genetic condition characterized by thrombocytopenia of variable degrees. Quantitative na pala to. Yung kanina, qualitative yun. But as you can notice, meron din silang some degree of quantitative defect. Pero by the books, classified sila under qualitative defect. Kasi the main problem is their function. So kapag kahit naman normal yung count ng mga nauna, pero dysfunctional ang platelets, qualitative defect pa rin yun. Ito, it's purely quantitative defect. So, where am I? So yun, there's thrombocytopenia of variable degrees, purpura and bleeding, giant platelets, and big well-defined basophilic cytoplasmic inclusion bodies. So what we call the Dolly bodies in your WBCs. Thrombocytopenia affects around half of MHA patients, though serious bleeding is uncommon. With surgical procedures, people may develop easy bruising, recurrent epistaxis. So lahat yan, it's non-specific symptoms of platelet abnormality. Alright, so dental considerations. Medications that reduce platelet function, such as aspirin, should be avoided. Mababa na nga yung count, bibigyan mo pa ng problema yung platelet function, so talagang duduguin ka dyan. Gingival bleeding can be reduced with regular dental care, and epistaxis can be reduced with the use of oily nose ointment. DDAVP or desmopressin is the standard treatment. Desmopressin 0.3 mg per kilo before and after surgery, and tranexamic 0.5 grams orally 3 times a day for 5 days following surgery as a local application by mouth rinse after dental extraction. Alright. So, tapos na tayo sa platelet, tapos na tayo sa vascular. Last would be your coagulation disorders. Right? So, toxic yan. So, hindi natin i-discuss. So, hereditary coagulation disorders, hemophilias are clinically relevant diseases. So, ang most common lang naman is your hemophilia A or your factor VIII deficiency, and hemophilia B, which is your factor IX deficiency. So, tingnan natin siya dito sa table. So, ito siya. Ito si factor IX. Si factor VIII, marami yan. Pali yan. Ang dami ginagawa. So, nandito siya sa intrinsic. Pero, wala pala dito sa diagram na to. Meron din siyang function somewhere here in the common pathway. And your factor VIII can also affect your extrinsic pathway. Kasi, in a normal hemostasis, usually, dapat they are independent of each other kasi, your intrinsic and your extrinsic. So kapag meron kang dysfunction dito, your extrinsic pathway can still form your stable fibrin plaque. Oo. Pero kasi, si factor VIII, ang problema sa kanya is marami siyang naaapektuhan. Meron siya dito sa common pathway, meron din siya somehow na kapag tumutulong siya para gumana sa extrinsic pathway. So kapag nagkulang siya, it can cause bleeding din. So si factor IX, understood na nandyan lang naman siya. So sa intrinsic pathway. So the end would be your stable fibrin plaque. So syempre kung kulang ka dyan, understood, hindi mo ito magagawa. Alright? So, Oh, okay lang. Ginagawa ko din yan. So, the clinical manifestations of both hemophilia A and B are relatively similar kasi nga, ang endpoint nila is fibrin flat. So, the signs and symptoms of hemophilia directly correlates with the coagulation factor activity levels. So, in cases of mild disease, yung factor activity niya is between 5 to 40%. They do not have any significant bleeding risk except invasive surgical procedure pag mild. So, kapag may traumatic event lang sila nag-bleed more or less. Yung moderate form, around yung factor level niya is 1 to 5%. They experience bleeding episodes in cases of trauma, mild surgical intervention, and dental procedure. So plus minus trauma yan. Pwedeng spontaneous or pwedeng trauma. So for severe, yung less than 1%, with or without trauma, duduguin sila. And they are very prone for life-threatening bleeds, yung intracranial hemorrhage, yung GI bleeding, kahit ako po lang sila pwede sila mag-bleed. Kasi konti lang yung level of activity of your factor 8 and your factor 9. Okay, so good to know pala, ang hemophilia, ang hallmark bleed niya would be your joint bleed, no? Deep muscle bleeds and your joint bleeds. They are the hallmark bleeds of hemophilia. Unlike your platelet dysfunction, mucosal ang bleeds, no? However, your hemophilias can still exhibit mucosal bleeds. Alright. So the infants with hemophilia can develop unexplained bruises while crawling or after intramuscular injections of vaccines. The risk of intra-articular bleeding increases as the age progresses. Intracranial and extracranial hemorrhages are one of the most serious complications of the severe form of hemophilia, commonly associated with traumatic birth injuries. The patients are more likely to present with hemarthrosis, that's a hallmark bleed, and muscle bleeding. In the oral cavity, hemophilia can present in the form of petechia. So somehow, it can present with petechia, hindi siya exclusive sa platelets. Ecchymosis and hematomas, especially in the floor of the mouth, tongue, labial frenulum, and palate. These patients can experience pronounced gingival bleeding during routine brushing, eruption and exfoliation of teeth, and oral prophylaxis procedures. So these patients are prone to gingival recession, progressive periodontal diseases, alveolar bone loss, and tooth decay due to the lack of oral health care. Again, takot sila nagdugo yung nila, kaya hindi napapabayaan nila.
Doc, yung
Yes.
hematoma under the tongue,
Mm.
gaano kaaga siya magmamanifest? Newborn?
Pwede.
Kita na rin po.
Pwede, yes. Ang problem with hemophilia, kahit anong klaseng form of bleeding pwedeng mangyari sa kanya. It all boils down kung anong klase or anong severity ng hemophilia niya. So if severe form siya, kahit anong bleeding pwedeng mangyari. Kahit spontaneous lang na nakaupo lang siyang ganyan, pwede siyang mag-bleed. So kahit ano talagang presentation.
Kasi Doc, we usually do tongue tie releases for
Yes, oo.
newborn. Kaso,
Actually ako nagagawa din nun.
kaso, ano nalalaman kapag pag may bleeding disorders for infants?
Ayun lang. So, well, ako as a pediatrician, hindi bilang as a hematologist to in our practice in pediatrics kasi, hindi namin siya pinapaabot in a crucial age of 2 to 3 kasi yun na yung speech development. Diba? So, hinihintay muna namin after some time kung talagang hindi na siya nakakakain or nahirapan yung kumain. Doon lang kami magre-release. Kung short lang yung tongue tie niya, baka pwedeng hindi na. Pero kung talagang makaka-apekto siya in the future in terms of speech, kailangan i-release. Ngayon, kaya kami naghihintay kasi hindi lang naman yun ang bleeding manifestations nila eh. Lalo na kapag newborn, kapag kinap yung umbilical cord, kung may bleeding disorder ka, pwedeng magdugo yun.
Doon pa lang.
Oo. Pwede siyang yung iba nadudugo yung umbilical stump. So, dun pa lang malalaman mo na may bleeding tendency ba to? Saka syempre, again, history pa din. Yun nga, yung history taking natin with the patients. So, that's very important. So, yun. Dental pearls. A comprehensive dental treatment planning is needed for the patients with hemophilia. Prior to the day of the dental treatment, the patient's hematologist need to be consulted kasi kailangan namin i-replace yung factor. So, a deep insight in the patient's dental history is required in terms of previous episodes of dental bleedings. So, hindi lang yan ang unang episode ng bleeding. Dahil hemophilia yan, dati penetrated. So, and the maintenance of oral health care. Depending on the type of dental procedure, the normal coagulation factor levels should be evaluated. So, dapat, hindi kasi, the thing is, halimbawa, pag na-diagnose mo siya as severe hemophilia, hindi niya magbago forever. Kasi it's a genetic problem. Papatasin mo lang siya, bibigyan mo lang siya ng replacement ng factor, pero the diagnosis is still the same, severe hemophilia pa din siya. Oo. Kasi wala naman niyang way para gumawa ng additional, but rather, kung di mo lang siya i-replace. So, the children should be psychologically prepared for the dental procedure to reduce their anxiety and stress levels kasi baka duguin din. Patients need to be guided to maintain proper oral hygiene and hemostatic agents must be made available in the dental OR while performing the procedures. Antibiotic coverage is given to treat the acute bacterial infection. Drainage of the abscess can be put the patient at risk for bleeding episodes and if necessary should be done under the supervision of the hematologist.
So,
Right.
kailangan
So,
po
yun.
namin mag-coordinate sa inyo.
Actually, oo. Kasi,
Magputok ng abs.
oo, hindi totoo. Kasi
Yeah.
duduguin talaga sila. As in,
Oo.
sa lahat ng mga problematic na hematologic disorders, ito yung talagang pinabantayan talaga namin. Mga hemophiliacs. Oo.
Magputok ng putok.
Oo.
Kasi Doc, di ba kasi pag may local yung abscess ng naman, pwede mag-recommend na warm water with salt and garlic.
Oo, yun, yung mga ganun supportive measure, oo, talagang kailangan naman talaga yun eh. But the thing with hemophilia, hindi yan, wala silang mechanism to spontaneously clot themselves. Kasi defective yung secondary hemostasis nila eh. So wala silang way. So hanggat wala silang enough factor sa katawan, hindi talaga sila titigil sa pagdudugo. Yun yung problema nun. Oo. So yun, kaya talagang kailangan silang bantayan. Alright, so...
Dok, may handline po ba kayo? Parang
automatic. Mamaya may slide. So yun, during your MOS procedures, yung mga ginagawa niyong MOS, minimum trauma should be induced to the soft tissues and proper suturing with surgical stent is required to hold the clot and promote the healing. So pressure to sa inyo kasi kailangan niyo siyang gawin ng mabilis. Mabilis, minimal trauma. So, tranexamic acid and IACA can be prescribed before the procedure and should be continued for a total of 7 days. The local hemostatic agents, pressure surgical packs, vasoconstrictor, sutures, topic thrombin, fibrin, and sealant glue, collagen gel, Surgicel, calcium alginate, ginagamit nyo ba lahat yan? Surgicel, oo, yun naman. And eye therapy should be in their dental clinics. Paracetamol is considered the safest analgesic that can be used in such patients. NSAID should be prescribed with the hematologist consultation, pero we discourage that. Although aspirin is strictly contraindicated in these patients, wala ka nang secondary hemostasis, papatayin mo pa si primary hemostasis, di duduguin yung patient mo. Alright? There are no absolute contraindications for the anesthetic administration. Inferior alveolar nerve block is used only after raising enough clotting factor levels with suitable replacement, as there is a danger in bleeding into the muscles and probably airway impairment owing to the hematoma in the retromolar and pterygoid region. So it may increase the chance of mortality due to the obstruction of the airways, and in many cases, intralegumentary or interosseous injections are used as adjuncts to these nerve blocks to avoid such complications. The cautious use of rubber dams, wedges, or matrix bands are advised under topical anesthesia to avoid the risk of bleeding episodes. Lastly, the most important goal of hemophilic patients is to maintain their oral hygiene to prevent the dental decay. So these patients should be instructed to undergo regular dental checks, fluoride applications, and avoid consuming sugary foods.
Doc,
Yes,
regarding yung patients na kayo po talaga yung primary pinupuntahan ng mga patients with bleeding disorders.
Yes.
How cooperative are parents regarding recommendation like going to the dentist by 1-year-old?
Oo, ganito
those
yan.
things?
Natakot namin sila. Dapat kasi matakot sila. Kasi it's a lifelong disease eh. So we emphasize yung risk and yung burden of disease ng bleeding sa kanila. So hindi dapat nila yung i-set aside, no. And the thing is with hemophiliac patients, ito yung ang ganda ng support group nito kasi meron silang samahan ng mga hemophiliacs, no. So once na may diagnosis kami ng hemophilia, binabato na namin sila sa support group. Actually, yung mga parents themselves, they educate each other kasi alam na nila yung yung galawan. So, yun. Pero we emphasize as their caregivers, we emphasize yung value. So, yan. Talagang binabato namin sila sa dentist. Kasi mas prevention is better than cure talaga. So, ayaw namin yung nagde-develop na abscess or kahit nga konting caries lang, binabato na namin sa dentist for prophylaxis and pasta. So yun.
Maybe we can make educational videos specific for hemophilia, ay for bleeding disorder patients and mas maintindihan nila kung bakit.
Though yung personally, yung mga patients with bleeding disorders, takot sila for themselves. Hindi dahil tinakot ko sila, pero they are takot dahil ayaw nilang magdugo. Oo. So yun. So, I think medyo patapos na tayo. So, after your coagulopathies, another thing is your von Willebrand disease. Yung von Willebrand disease also is a part of your primary hemostasis, kasama niya si platelet. And then, it's also a part of your secondary hemostasis, si von Willebrand, kasi nakakabit siya kay factor 8. So, cofactor siya ni factor 8. So, it's both affecting your primary and your secondary hemostasis. So, your von Willebrand disease is an inherited bleeding disorder characterized by deficiency in plasma von Willebrand factor. Mild diseases of von Willebrand are usually asymptomatic and is routinely diagnosed during blood investigations in case of a positive family history. So, asymptomatic sila most of the time. Malalaman mo lang kasi yung nanay nagsabi, Dok, may von ako. So, yun. So, yes. So, unlike hemophilia na lalaki ang symptomatic, this disease equally affects both genders and manifests as bruising of the skin and multiple mucocutaneous bleeding. In contrast to deep subcutaneous bleeding that happens in cases of hemophilia, these patients can also have epistaxis, prolonged bleeding time, increased post-traumatic bleeding, and increased postpartum bleeding episodes. The severity of the symptoms depend on the type of von Willebrand kasi there are multiple types of your von Willebrand disease. Type 1 accounts for 60 to 70% and they have milder manifestations. So, type 2 accounts for moderate signs of symptoms and type 3 is the severe variant of the disease. Patients with type 3 can develop severe pain and swelling in the joints and soft tissues due to increased bleeding. Increased gingival bleeding during routine prophylaxis procedures and bleeding following teeth extraction are the common oral presentation of the disease. Red, soft edematous gingiva with loss of stippling can be seen in these cases. So, the presence of ecchymosis and purpuric spots in the oral mucosa are frequently seen. So, before initiating dental treatment, the diagnosis of the von Willebrand disease needs to be confirmed by the hematologist. According to the type of disease, dental treatment should be planned for these patients. Patients ought to be counseled about maintaining their oral hygiene practices. Before conducting any invasive procedures, Desmopressin or DDAVP should be administered for prophylactic purpose for this patient. Intraoperative bleeding should be controlled using local hemostatic procedures like gel foam, fibrin glue, and followed by good sutures. Avoid aspirin and NSAIDs in these patients. However, paracetamol can be prescribed. These patients need to be observed for further 24 to 48 hours for any signs of bleeding and allergic reactions.
So, ang desmopressin, kayo na po nag-administer na po.
Oh. Pero pwede din naman kayo. I think so. I think pwede din. So, itong mga minor na lang na bleeding disorders. So, hypo or afibrinogenemia. So, ano ba yung fibrinogen? Fibrinogen ay nandun sa coagulation cascade natin. Siya yung last. Siya si factor 1. So, definitely, kung wala siya or mababa siya, it will cause bleeding. Alright. So, it is an autosomal recessive coagulant disorder characterized by partial or complete absence of fibrinogen. These patients can occasionally develop mucocutaneous or post-traumatic or soft tissue bleeding. Females have been reported to have excessive menstrual hemorrhage, and delayed wound healing has also been witnessed in some of these patients. Konti na lang. So, dentists commonly encounter these patients as a diagnosed case of afibrinogenemia. So, pag dumating naman sa inyo, diagnosed na siya already. Kasi, neonatal age pa lang, meron na. So, the preventive treatment plan should be customized for these patients. These patients should be educated first about the severity of the disease and its impact on the dental tissues. Fluoride varnishes must be applied in these patients Q6 months to prevent dental decay. Oral prophylaxis is indicated in these patients with minimal soft tissue damage, as there is a risk for excessive bleeding. Minor invasive surgical procedures should be dealt cautiously, and blood coagulation test is mandatory. If the blood fibrinogen levels is below 100 milligrams per deciliter, the prophylactic plasma-derived fibrinogen concentrate or cryoprecipitate or FFP should be administered for these patients. Antifibrinolytics in combination with fibrinogen replacement are helpful in the control of mucosal bleeds, especially bleeding during dental treatments. IACA and tranexamic acids can be administered orally or intravenously. Antifibrinolytics can be used in conjunction with fibrinogen replacement to control intraoral bleeding following dental procedures. Alright, ito last na. So now that we discussed the congenital and hereditary causes of bleeding in childhood, let me discuss briefly just one acquired cause of bleeding that primarily affects platelets that can be seen fairly commonly in pediatric practice. So acquired to pero medyo marami siya. So throughout life, the normal platelet count is about 150 to 400, while other books would say it's about 450. Since thrombocytopenia is associated with abnormal bleeding in general, excluding qualitative platelet properties, the severity of the hemostatic defect is proportional to the platelet count. Right? So sabi nila, well, hindi sabi nila, ito talaga yun. So around 100 to 150, okay lang mag-over ka. Wala namang problema, sir. Pero pag mas bumaba na, dun 50, medyo may risk na siya for bleeding. Alright? Pero definitely, pag less than 20 yan, magsasali na kami ng platelet dyan bago ipa-clear nyo na sa akin. Oo. Kasi basically, ano yan eh, oo nga. So yun nga, it depends on the count. So these are the acquired causes of thrombocytopenia. The correct diagnosis can be made by taking full history and PE, with some requiring a bone marrow examination. Pero, i-drop natin lahat yan. What we will discuss is this. ITP. So acquired siya, pero medyo madami siya. No? Even in adults, marami din ng ITP. So, your immune thrombocytopenia is formerly known as your idiopathic or immune thrombocytopenic purpura. It is due to excessive platelet destruction brought about by formation of autoantibodies against a platelet receptor. The usual presentation of them is a platelet count of less than 50,000. And they usually present with skin purpura and or bleeding from the nose, mouth, and gums. So, in young children, average of about 1 to 4 weeks post-viral infection, so yung mga simpleng ubo-sipon na yan, or even a post-live vaccination, so yung mga vaccination na MMR, measles, mga live vaccines yan. So, minsan nagde-develop ng ITP because of that. The problem with ITP, kaya siya bumababa kasi, like halimbawa, di ba pag live vaccines, ang mechanism kasi niya is minimimit niya yung virus eh. So that's your, and then your immune system would be doing the antibodies against the viral component inside the vaccine. And kapag nagkaroon ka ng upper respiratory tract infection o mga viral infection, yung virus na nasa loob ng katawan ng bata or ng individual is morphologically similar with your platelets. So pag gumawa ng antibodies yung katawan mo against the virus, somehow it will affect or it will attack the platelets. So that's the mechanism of your ITP. Nasisira yung platelets kasi kapareho niya yung viral surface and your platelet receptor. So that's why yung mechanism niya, it will happen around between 1 to 4 weeks post-infection or post-vaccination. Kasi that's the time your immune system does your naturally occurring antibodies or your acquired antibodies. So kaya doon bumabagsak yung platelet. Okay? Kaya siya immune. So in general, around 80% resolve in about 6 months. But 20%, especially during in adolescents and adults, they tend to be chronic. So they tend to have a lower platelet count beyond 6 months. However, sa ganitong age group, we need to rule out secondary cause like yung usually mga lupus, yung mga HIV. So, nirule out namin yun kasi it's very unusual for that age group to have ITP. Pag bata, okay lang yun, usual na sakit ng bata yan. Pero it will resolve dapat. Correct? So, in general, for symptomatic patients, expect treatment with IVIG. So, hindi naman lahat ginagamot namin na ITP. Minsan pinapabayaan namin kasi with the premise that they will resolve its own. Sa akin wala namang bleeding, ba't namin gagamutin? Kahit mababa yung platelet count niyan. But for some, we need to treat them with IVIG and corticosteroids. Kasi diba ang mechanism ng IVIG, lalabanan niya yung antibodies na na-form. So, yung abnormal antibodies na na-form ng katawan mo, lalabanan ng IVIG. So, for failure of platelet production, kapag hindi pa rin talaga nakagawa ng platelet, expect replacement therapy with platelet concentrates, pero that's given in severe or in rare cases. Aspirin, drugs that containing aspirin and NSAIDs should be avoided. Paracetamol and codeine are safe, and no intramuscular injection should be given as they are prone to bleed. But subcutaneous and intravenous injection may be given where necessary. Again, baseline platelet count should be obtained prior to any invasive procedure. So, in summary, children with various bleeding disorders are a significant challenge for clinicians and you, the dentist. A child with mild or moderate bleeding signs is nevertheless a diagnostic difficulty. In children, bleeding disorders often present at a younger age, reflecting the congenital nature of the hemostatic disease. Even as dental professionals, it's imperative for you to screen the personal history, family history, and current medications to unravel bleeding tendencies in the patient. It is important to work hand in hand and prompt referrals made to the pediatrician or to the hematologist for optimum multidisciplinary care. So, the early stage in the evaluation would be objectively quantify his or her bleeding symptoms, followed by objectively quantifying the bleeding symptoms of his or her family. Finally, if the bleeding disease is detected, specific tests must be performed. Coagulation factor deficiency screening tests are believed to be routinely available and simple to use. So the current paradigm emphasizes that patients with bleeding disorders can be managed safely in the dental setup if certain guidelines are followed. Dentists must be aware about the clinical presentation of these disorders, possibility of associated bleeding complications, and management protocols that need to be devised as an outcome. It is important to ensure clear channels of communication and close collaboration with the hematologist prior to any dental procedure, taking a thorough and good elaborative medical history, adhering to hemostasis principles, and applying sound clinical judgment, together help to ensure the patients with bleeding disorders receive effective dental therapy. So yes, with that, that's my final slide. So, yun, ito yung number. Then yun, no. As I know, serving naman ako. So, I can also give you my contact number. Ano, no? Oo.
Same dome.
Oo.
Malapit na sa inyo.
Ayun. If you have any questions.
Doc, yung sa this
Yeah.
blessing, kailan siya ibibigay? Hours before, day before?
Usually binibigay namin siya prior to the procedure.
Mismo.
1 hour.
So sa inyo muna bago magpa-denta? Yung gano'n? Or
I'm not really sure kung...
appointment
I'm not really sure, Doc, kung nagpe-press. Pwede kayo... Ano ba yung pwede mo? I mean, ano yung pwedeng
I've only
i-prescribe?
had one time na mayroon akong 1 milligram sa patient. But,
Mild lang yun siguro.
kailangan.
Oo, baka mild lang. Mostly naman, asymptomatic nga din eh.
Yung kanina.
So yun, I don't know kung ano yung limit na pwede natin
Ito ba yun?
sa dental practice nyo. So,
So, ano pwede naman kung
kayo yung magpa-prescribe?
oo naman. Wala naman. Kaya lang, ang worry ko is yun nga, for me kung ako tatanungin nyo, I think pwede naman siguro kayo mag-prescribe. Pero syempre, siguro kahit pa-clear nyo na lang din para safe. Para safe. For safety reasons.
i-coordinate na lang natin yung appointments natin with the administration of the desmopressor before the procedure itself. Pwede po ba din na maano sa phone number ninyo?
Sure. Oo. Sige. Oo, no worries. 0918. Di ko pala nilagay, no? So anyway, it's 0918-454-2847.
So with your platelet transfusion,
Yes.
parang matagal po siya na stable yung platelets niya for a dental procedure. Kapag nagkaroon ng transfusion.
Ganito yan. So kasi, depende kasi. Like, halimbawa, yung diniscuss ko, yung ITP. Ang mechanism kasi niya, i-destroy niya yung platelets. So, sometimes, an hour or so, or hindi naman hour, siguro after some few hours, kung active ang ITP niya, sisirain niya na yung platelet. Oo. Pero kasi, yung ibang bleeding disorders, yung mga quantitative platelet disorders, if hindi naman nila ang mechanism na nagsisira ng platelet, kasi di ba, genetic naman yun. So, if ibang mechanism nila, we would expect ang stable platelet count in around 8 to 10 days. Kasi yun yung lifespan ng platelet na sinalin mo. So, yun. Pero kung ang mechanism ng pagbaba ng platelet is dahil nagsisira siya ng platelet, hours pa lang, we expect na mabagsak siya. Oo. Pero that's rare naman. I mean, actually hindi naman kami nagsasalin right away kasi alam nyo, ang transfusion has its own risk. Minsan, the risk outweighs the benefit ng transfusion. So as much as possible, hindi kami nagsasalin right away kung hindi naman kailangan. So yun. Question? Yes.
Doc, share ko lang po, it happened last Tuesday. Parang may patient po kami na for tooth extraction po due to trauma. Upon history po, the mother mentioned that nasugod daw po yung anak niya nung 1-year-old siya due to high fever because of platelet problem. So, after po this lecture, parang na-realize ko, baka may...
ITP, no?
Yes po. So, if ever, Doc, pwede po kong ibigay namin yung contact ninyo for advice for them po for clearance.
Hindi, ganito.
For consultation.
Actually, as much as possible, hindi ako nagbibigay ng personal numbers sa patient.
Yeah.
So, ganito na lang. Gawa na lang kayo ng referral
Opo.
address to me. Oo, sa pinakamalapit na hospital na affiliated siguro ako. Then they will set an appointment with the secretary. Or pwede nyo to ibigay. Kasi dito may personal, may ano to eh, may appointment, something yung, oo. So yan. Pero, for you naman, hindi, for you naman, okay lang na ibigay yung number ko. Pero kasi mahirap kasi sa patient.
Kasi dito sa clinic.
Dr. Sir na yung
454-47.
Sabi sa'yo nito, open-minded ka man.
Networking.
Finance.
May agent ako ng Sun Life kaya.
Ano yung kanina rin kasi? Ikaw. Ano kanina?
Kaya nga eh, binigyan niyo ako ng palikat. Sorry. Sorry, nasa bulsa ko lang.
Sunlight tayo. Sunlight.
Piolo Pascual kami.
Health life insurance.
So I hope hindi siya masyadong highfalutin sa inyo. And if you have any questions, don't hesitate. Yes.
Usually po yung mga patients nyo, ano po yung frequency ng recall sa inyo? Meron ba silang recall ng every 3 or every 6 months?
Follow up.
Yes,
Yes.
po.
Oo naman. At any consultation, we always emphasize the importance of follow-up. So, depende naman yan sa case. Kung kailangan mo ba siya, kung ganun ba siya ka-toxic bantayan. So, minsan every week nga, kapag acute bleeding episode, talagang babantayan namin yan eh. So, depende. It's a case-to-case matter naman.
Para po kasi kung sakali may mga patients na, kailan po kayo last nag-visit sa physician nyo? Sabi nila, ay, last year pa, a year ago. So, parang doon pa lang maano na namin na kung kailan ba yung mga lab test nila dapat.
Oo. So, yun. Siguro, ewan ko pero kasi, I don't know kung kung applicable din sa inyo. Pero kasi sa amin, once in doubt, always refer. Oo. Always, iba nyo siya.
Pag wala pang di na po makasagot sa amin ng parents dun sa details po, we send the parents na
Go.
balik sa physician nila.
Oo. That's the safest. That's the safest kasi. Mahirap kasi yung parang kayo lang yung gagalaw. Oo.
Scan the QR code.
May gamit ka ba nito?
Ayan.
Send po namin sa Speaking of when in doubt, kasi pagka may mga patients po kami for sedation, we ask for lab test. So it includes the PT and PTT. So sometimes po hindi normal range, pero kiniklear po ng pedya and no recommendations if kailangan ba nilang mag-visit sa HEMA or kung ano bang dapat.
Alam mo,
Should be.
yan. Oo.
Or
I
parang
understand
bypass.
them kung ginagawa nila yun kasi it's their call. It's their call actually whether to refer to us o hindi. The thing is, in terms of you guys as dentist, at least meron kayong clearance from a doctor. So it's their call naman kung i-refer nila sa amin o hindi. Baka they are just matapang enough to clear the patient. Hindi naman in fairness, hindi naman lahat kailangan i-clear namin. Kasi nga sabi ko sa inyo, it all matters on the history and physical exam. Kung hindi naman siya high risk for bleeding, wala siyang bleeding tendency. Kahit na hindi naman niya nagre-rely lang sa laboratory test eh. It's not. It's more of the history and the physical exam. Doon naman nagbe-base yun. So in fairness to them, it's their call talaga. Pero at least on your side, meron kayong
Safety net.
meron kayong safety net. At least, in-clear siya nung pedya eh. So, wala kami doon. Wala kayo doon. Diba? So, yun lang naman.
Dapat, mas test to check? Is it INR or
Hindi.
PDI?
Ah.
What would be
Okay.
the metrics that
Sige.
we get to look at?
Okay. So, ganito yan. Hindi lahat. Okay. Siguro, kasi sa amin, sa recommendation namin sa hematology, actually hindi na nga masyadong advocated ang pre-op labs. I mean, kung hindi siya strong talaga sa family history or sa any bleeding tendency, hindi kami left and right nagre-request ng CBC or X-ray pre-op. Hindi na. So, even your PT, PTT. But, if ever na meron ng labs na dumating sa inyo, ang pinauna nyo titingnan dyan, syempre, is kung ang concern nyo is bleeding, ang titingnan nyo dyan, platelet count. Ang titingnan nyo dyan, PT-PTT. And when you look at the PT-PTT, you don't look at the control, you don't look at the INR, you just look, actually yung test hindi din, yung control and yung INR hindi, or even the percent activity hindi. Ang titingnan nyo is yung test, yung mismong value nung nakuha ng patient, and then you compare it on the normal value sa gilid. Hindi mo siya, actually yung mga pedya din, minsan nagkakamali sila. Kino-compare nila sa control. It's not significant eh. Ang dapat nyo i-compare to is yung normal value sa gilid. Kasi that's our parameter. So yun yung titingnan nyo. Same with the PTT. We don't look at the control. So, yun lang. Obsolete na din ang bleeding time. Actually, ang clotting time, obsolete na rin yan. Hindi yan tinitest kasi it's very subjective. It's operator dependent. So, hindi siya objective. And it's not clinically valuable anymore.
Paano po yun? Kasi po here, if we have more than 2 to 3 tooth extractions, basing dun sa nilabas na guidelines ng association namin for pedia and other sedation, that we get to request for those tests. Within the context po yun ng guidelines
Oo.
ng pediatric dentistry. Paano po gawin namin for that?
Meaning, ano ba, Doc? Parang, ano bang dilemma natin dyan? Kung i-clear nyo ba?
Kung should we request pa po ba? Kasi whatever na nilalabas sa guidelines, we follow. Like, requesting for the bleeding time, cutting time, all those blood parameters.
Okay. For the sake of your guidelines and for the sake of your safety, you follow your guidelines. Pero, ang clinical decision yan would ultimately depend on you. And in my opinion, as a hematologist, yung mga sinabi ko, yun yung mas matter. I mean, yun yung mas titingnan ko. Pero for the sake of compliance to your society and for safety reasons na nag-comply kayo, wala namang masama na i-follow nyo yun. At least meron kayong safety net. Pero if in terms of clinical significance, kung nagmamatter ba siya, kung may difference ba na gagawin with those tests, mag-iiba ba yung management nyo? Parang hindi. Oo. So yun lang. Anyways, so may question lang. May gusto mo kayo clarify.
Questions? Si Doc na yung magtatanong sa susunod.
So yun. So I hope hindi siya ganun kalalim. Yun yung worry ko when I did this lecture. Parang, yeah, I understand naman na we are allied health naman. Pero syempre, I need to help you, make you understand everything. So yun.
Thank you po.
Yeah, thank you.
Thank you.